Dr. Darin Okuda is a professor in the Department of Neurology at the University of Texas Southwestern Medical Center, where he's also the director of the Multiple Sclerosis and Neuroimmunology Imaging Program, the director of Neuroinnovation, and the deputy director of the Multiple Sclerosis Program and Clinical Center for Multiple Sclerosis at UT Southwestern. My own observation is that Dr. Okuda is also one of the truly innovative and original thinkers in the MS space. Welcome to 2025 ACTRIMS Forum, and welcome to Real Talk MS.
Thank you. Thanks for having me. Thanks for the invitation.
Tomorrow, you'll be co-chairing a session about connecting data to the clinic using machine learning. AI is certainly a hot topic that has the potential to impact so many different aspects of our lives. How do you see artificial intelligence impacting MS patient care?
So I think AI will transform the care for people with multiple sclerosis in a variety of ways. One includes how we diagnose people. I think the second may involve identifying the best therapeutic paths or even treatments for them. And also I think that AI will play a significant role in how we interpret diagnostic test results and other paraclinical studies. So tomorrow you'll be hearing from some scientists that have leveraged artificial intelligence in helping us to understand data that's right in front of us better, which is how we should be using the system, is to allow for us to see things that aren't there, to allow us to generate new ideas, new hypotheses, so that we can create platforms for better care.
I can see how AI is going to be embraced in academic settings, certainly. When it rolls out into community clinics, what do you think the reception is going to be?
So it's hard to know. And I think how AI is going to be used in clinics will differ from maybe the perceptions of physicians in terms of how we think it should be used. I think one way that it will be used will be to answer questions that patients may have when they submit messages via MyChart, so an automated response. I think you'll see elements of that. The other involves interpretation of laboratory test results that are normal, so not dealing with those that are abnormal, but then reaching out to people with multiple sclerosis that have had recent diagnostic studies with normal results. Very easy to communicate what's normal to people. And then in the community, you may have a mixture of those two things, but then also it may be coupled with new paths that maybe would not be used in an academic setting. And that could be guidance to other healthcare platforms during office hours or when office hours are closed, to even recommendations for non-pharmacologic therapy. So I think that the community has an opportunity to maybe leverage AI in a very different way, allowing them to perhaps pivot more rapidly than, say, an academic institution with respect to patient guidance.
I'm going to switch gears, and I'll probably do that a couple times during this conversation because you have interesting work in so many different areas. But let me ask you if you wouldn't mind explaining what radiologically isolated syndrome is, and then talk a little bit about the ARISE study.
Okay, so the radiologically isolated syndrome is a syndrome that really encapsulates individuals that have an abnormal MRI scan that occurred for a reason, for imaging that was performed for a reason other than for the interrogation of MS. So these are people that were involved in car accidents. These are people that have migraine headaches. They're involved in other traumatic events. Maybe they undergo a healthcare screen. In one example, these are people that also are young individuals who are participants in clinical trials within academic institutions. So they're compensated $75 to be a normal control within an MRI study, and lo and behold, we find things consistent with MS, yet these people have no symptoms at all when we look back in their medical history and we interrogate them. The ARISE study was the first therapeutic trial in RIS that demonstrated a treatment benefit of Tecfidera in delaying or preventing the onset of a first acute clinical event related to MS. Very exciting, first of its kind. There is a sister study called TERRACE that was championed by Dr. Christine Lebrun-Frenet in France that looked at Albagio, teriflunomide, having the same primary outcome as ARISE. And both studies were positive studies demonstrating a therapeutic effect in people with RIS, which is very exciting to see. And this really has allowed us to perhaps reevaluate our current definitions of multiple sclerosis and for us to maybe expand the spectrum of multiple sclerosis even more.
You've done some work focused on ways to prevent MS. How can those insights be best applied?
So, well, that's a great question. So one is, I think, working towards a system where we're better able to identify who would benefit the most from early treatment, and having further studies that really allow us to offer a different form of counseling to people that may not need treatment or those that may never need treatment ever in life. It does really allow us to really understand the biology of MS, and I like to think in a very different way because we've identified certain changes within a person's brain that seems very heterogeneous. So some people may be aging a bit more rapidly even before their first symptom, but also even before their first lesion that develops in their brain based on some early work in our program. So I think there's a large spectrum of what we actually can do, and I think it really starts first with refining our knowledge so that we know who we best can help most quickly, and then working towards achieving those other goals in the application of what we've identified both in ARISE and TERRACE.
You published a case that you were involved in. It involved an MS patient who had been stable for a number of years and then, quite surprisingly, unexpectedly, suffered a relapse. What did you discover as you looked into that case?
So this is an individual that was stable for 30 months on brand name teriflunomide, Albagio, and in June 2023 was forced to transition to generic teriflunomide based on a third-party administrator recommendation, or I would say edict. That was appealed unsuccessfully twice, and this person was placed on generic teriflunomide. And within a number of months, from June, July to late October, early November, developed symptoms consistent with a spinal cord relapse. And this person had 2 spinal cord lesions that were new and enhancing. So I actually recovered the generic treatment that she was taking, and I submitted it for independent testing in an FDA-approved, DEA-certified laboratory. Now, the FDA requires that the content fall between 90% to 110% of the stated label. So being on 14 milligrams of teriflunomide, the content needed to fall within that range, 90% or 110% of 14 milligrams. And 10 tablets were randomly sampled and submitted. The average content for the 10 was 55%. So subpotent from where it should be. So I think the learnings here are that, there's another dynamic that we've included in the care of people with multiple sclerosis. We have to pay attention to generic treatments that people may be exposed to and having them have knowledge on which manufacturers they're receiving the medications from, if the tablets or pills look different, if they taste different, and just advising them that within a given calendar year, you may be exposed to 2, 3, 4, 5, 6 generic manufacturers. And the tolerances for these generic treatments vary. And where they're manufactured also vary as well. And that could play a huge role in the quality of their treatment.
What are you seeing in MS research today that excites you?
I think there's a lot. I think there's work looking at treatments that may address the disability aspect more so than the focal inflammatory insults. I think this morning there was great talks involving the genetics of MS and autoimmune disease in general. I think there are approaches that aim to allow for greater access of MRI sequences to allow for the observation of paramagnetic rims and central vessels by Pascal Satie. That's very exciting. I think there are new MRI approaches that are being looked at to study connections within the brain that may be informative on understanding why people suffer from fatigue a lot And the list goes on. And of course, we're always biased to the work that we do, but we do a lot of high risk, high reward type of studies, and most of them have failed recently, but still, we still try.
And you learn through the failure.
We do, yes. 1,000 or 2,000 different ways on how not to do something. Like the light bulb, we come up with that fairly often.
Exactly. Well, Dr. Darin Okuda, I want to thank you for being willing to hang in there and keep failing your way up, because somehow you managed to improve the quality of life for everybody living with MS. Thanks again for talking with me.
Thank you very much. I appreciate it.